So we'll talk about oral cancers, and since more than 90% of oral cancers are squamous cancers, we'll confine our talk to squamous cancers and not go on to the salivary neoplasms or melanomas. First things first. So what do I do?
No, they can hear. No?
Yeah. So before we come to the treatment, a few points that I need to emphasize on establishing, confirming a diagnosis. Most of the oral cancers, we will be able to confirm the diagnosis, histopathological diagnosis on a punch biopsy, and most of the times it is an office procedure, a punch biopsy taken from the floor of the ulcer, not from the edge. Very rarely do pathologists insist that they cannot make a diagnosis on that and they need a biopsy from the edge. In that case, you have to do local infiltration and take it. Or if the tumor is submucous, then you will need to do local infiltration. Because most of the times a punch biopsy as an office procedure will be done. But one of the points that we need to emphasize when we give CMEs to our colleagues in ENT, our colleagues in dental surgery particularly, is that an excision biopsy should not be done. In most of the situation in oncology, an excision biopsy is not a wise thing. Once they excise the lesion, not knowing what they're excising, is it an inflammatory ulcer, a traumatic ulcer, or a malignant ulcer? And then if the report comes as not malignant, then you have done more than what needs to be done. And if the report comes as malignant, then you have not done adequate. And then to do an adequate excision, the patient ends up losing a lot more of the tongue, and where he would not have required a flap for reconstruction, he may now need a flap. So most situations in oncology, excision biopsy is not a wise thing. Do what you do after knowing what it is that you are doing. In breast lumps, also you have seen so many times patients come with an excision biopsy. They've lost the chance of breast conservation therapy because of that excision biopsy. An incision biopsy, small incision biopsy is good enough for the pathologist. One particular entity, verrucous cancer, a subtype of squamous cancer, is one of those cancers where the clinician will use his judgment and do the excision. Because going on repeating a biopsy, pathologists will not be able to tell you whether it is malignant or not. But if you see that pearly white fronds of verrucous cancer, you are justified in going ahead and excising it. Give the specimen to them, they will tell you whether it is a verrucous carcinoma or whether it is just a verrucous hyperplasia. That kind of lesion needs to come out. Not happy. So for early oral cancers, that is stage 1 and stage 2 oral cancers, we are dealing with T1 or T2 N0 M0 cases. These are usually amenable to per primum treatment with a single modality. And the various issues that we can discuss, and maybe skip some of those for want of time, is what is that single modality that is best for early oral cancers? Is it surgery or radiotherapy? What should be the surgical approach? What should be the margins of resection? How does one manage the mandible in oral cancers? How do we manage the neck, even though it is T1 N0? Management of the neck is an important consideration in all oral squamous cancers. How do you reconstruct the defect, and what is the role of adjuvant treatment? Even though this is a tumor which requires single modality treatment, Nearly one-fourth or one-third of them we will ultimately find are not early and will need adjuvant treatment, and which is that subset that requires adjuvant treatment. Surgery has several advantages. There's a shorter duration of time. It provides good histopathology, which may then upstage the disease. We know the real stage of the disease if you've excised it, and it avoids the lot of toxicities of radiation therapy, particularly in this country where a good component of the oral cancers have some mucus fibrosis, where radiotherapy is not well tolerated. And a large number of our oral cancers, as we have seen in our practice, are recurrent cancers or second cancers. And if radiotherapy has not been given earlier, surgery can be repeated, unlike radiotherapy, which can't be repeated very quickly at least. There are only a few situations where radiotherapy may be preferred, particularly when excision is going to compromise function a lot. And one of the situations that I can think of is a superficially invasive but very diffuse cancer, field changes. So A, it has to be superficially invasive. A deep invasive cancer will not respond to radiotherapy. And if the margins are not well defined, sometimes in palate you have this field cancerization with the lesion or scattered lesions, then radiotherapy is the preferred option. There will be no randomized clinical trials on which of the two is better. There are two very large retrospective studies, very good ones, which have very clearly shown that the overall survival, the disease-free survival, is better with surgery as the primary treatment for early oral cancers. Almost twice as good overall survival, 70% versus 35%. That's the kind of difference that very large retrospective studies have shown. Patients often ask if they will do laser surgery. Often they will ask, and companies will always recommend that laser does less fibrosis, laser is less painful. I think that all of that is to be taken with a pinch of salt. Do laser excision and leave the area raw, it pains a lot. In modern day cautery charge so much less that I don't think that there is a great difference in fibrosis from cautery excision or knife excision as compared to laser excision. The only place where laser has an advantage in oral cavity is in carcinoma in situ, a diffuse lesion or localized lesion in erythroplakia. You can excise that with the laser, and that is acceptable. But an invasive cancer, T1 also, there's no advantage of doing it with the laser as against doing it with the knife or with the cautery. The approach to excision, if the mouth opening is good, there is no submucous fibrosis, the large majority of the oral T1, T2 oral cancers can be excised by the intraoral route. But if there is a submucous fibrosis, the intraoral access is limited, the lesion is more posteriorly located, going towards the floor of the mouth, then you may need to have additional access, either with raising a cheek flap or doing a mandibulotomy. Raising a cheek flap will render the chin insensate because the submental nerve is divided. So to that extent, a mandibulotomy does have an advantage. With mandibulotomy, if you do, you have to have very good instruments, an oscillating saw that does not cause bone loss, and then of course, very good fixation. Then you are justified in doing that. Otherwise, if you don't have good instrumentation, then it is better to raise a cheek flap. In buccal mucosa cancers also, sometimes the access is difficult if it is going very close to the gingival sulcus above or below. In that case, it is better to raise the cheek flap and get a proper three-dimensional excision of the lesion. How much do you excise? To the pathologist, they want a 5 mm clear margin. Then they will say the margins are clear. Otherwise, less than 5 mm margin is considered as closed margin, and it keeps worrying the surgeon and the family a lot. A margin less than 1 mm is an involved margin, and that definitely requires treatment. But a 5 mm margin is adequate. We have to remember that after we excise, the tissues shrink. So by the time it goes to the pathologist, and particularly by the time it is fixed in formalin, the margin will shrink a lot. In that case, you have to take more than 5 mm for the pathologist to see that it is 5 mm. So 8 mm, 9 mm, 10 mm is the kind of margin that you have to excise. And sometimes, when the tumor has approached the floor of the mouth or the gingival buccal surface, you may not get that real 5 mm margin. And if the surgeon is satisfied with the suppleness of the tissue there, then a little less than 5 mm margin, 4 or even 3 mm margin is acceptable provided the surgeon is satisfied with that excision. We don't really need to extend it and go across to do a marginal mandibular or excise the teeth, extract the teeth and go beyond. If the teeth are very bad, and in any case need extraction, then of course you extract the teeth and then take the mucoperiosteum for floor of the mouth, the lingual mucoperiosteum for buccal mucosa, the buccal mucoperiosteum, and get that additional 2 mm that you may need to get an adequate margin. How important adequacy of margin is shown in these couple of studies, which have shown that recurrence rates were pooled to give a 21% absolute risk reduction in local recurrence with margins that were clear by more than 5 mm. That is the kind of impact that clear margin has. So it is a very important thing that the surgeon has to achieve. Another study has suggested that a margin of 2.5 to 5 mm, if it is a clear margin, is also adequate, and that getting margins more than that has no advantage. They've gone up to 7 mm. This is more than 7 mm. There is no advantage in getting more and more and more margins. And that is why it is important to know. It is important for the surgeon to remember that getting adequate access is very important. If you don't have adequate access, sometimes you excise too much and lose a lot of volume of the tongue only because you don't have adequate access. So sometimes you will find that posteromedially, a lot of the tongue gets lost, which can be preserved if you have a good access and a good approach to that excision. So getting more and more is not necessarily better. 5 mm margins is good. These people have shown that even 2.5 to 5 mm margin, their clear margins is good enough. This is a study that is suggested, that has studied various extent of margins and has shown that going beyond 5 mm, beyond 7 mm has no advantage. A lot of studies have been done to see whether frozen section is essential. And a week or two ago, we heard in our own meeting here, Dr. Chinoy talking about the frozen sections, whether it is cost effective to do that, so much load on the pathology department. But I would say that when you do an excision, the surgeon has to feel that specimen, and you think you are doing a good job, and once you get the specimen out, you find this doesn't look good. We are close, we can palpate the tumor. We not cut through the tumor if we are not far enough. In that case, it is safer to just excise that. Most of the times it will happen in the base, either in the cheek or on the tongue. So no harm in doing a frozen section or just excising an additional margin and getting a safe margin. Otherwise, the surgeon and the patient and the family will all keep worrying about that margin. And the patient may end up needing more treatment when he may not otherwise need it. Maybe on margin. Management of the mandible is very important in oral cancers, and at one time, segmental resections of the mandible were done just because of the proximity of the tumor. But today, with good instrumentation, good oscillating saw, we can get a wider margin, getting rim of the bone out, and not really sacrifice the segment of the mandible to give a good cosmesis. Management of the neck becomes an integral part of management of squamous cancers of the oral cavity, even in T1 and T2 cancers. And for a long time, this thing was debated, and a wait and watch policy was followed, particularly where work volumes are very large. A lot of patients are waiting for surgery. That you excise the lesion and feel when it's an early cancer, and you just wait and watch. And a lot of studies were done where no clear difference was seen in the overall survival in the wait and watch policy versus doing elective neck dissection for an N0 neck. Until this study came from the Tata Memorial Dr. De Cruz's study, we showed very clearly that if you do an elective neck dissection and not wait for therapeutic neck dissection till the nodes appear, the overall survival and disease-free survival is much better, much better. And that is where today the standard of care, with the parameters that we have today, elective neck dissection for T1, T2 oral cancers is the way to do. If it's a very small tumor, very superficial tumor, one is tempted to not do the elective neck dissection. And there may be a role for that. In this study itself, there was a suggestion that if the depth is less than 3 millimeter, then it is avoidable. It has not made any difference whether you did elective neck dissection or you did waited for a therapeutic neck dissection. But that number was small, so they cannot have a conclusive decision making in that situation. So this is that wonderful study that Tata Memorial came up with. This is another study from China, which pooled 6 prospective studies of elective versus therapeutic neck dissection. And once again, they have shown that one thing they showed was that the incidence of occult lymph node metastasis was as high as 30% in T1, T2 cancers. And they also showed that elective neck dissection reduces the regional recurrences and deaths related to that in early stage oral squamous cancers. So once again, for even an early oral cancer, T1, T2, with N0 neck, it is safer to do a elective neck dissection. Reconstruction for tongue defects, either a primary closure is done or a flap is used. If the loss of volume is almost 30 to 40%, then a flap is used. In very few cases, we will leave to heal by secondary intention, covering it with collagen. If the resection of the tongue involves floor of the mouth, then the indication for a flap reconstruction is more, because otherwise it just anchors the tongue down and speech gets affected very much. For gingivobuccal complex defects, either a primary closure or locoregional flaps or free flap. It all depend upon the size of the defect. We have all seen that if there is submucous fibrosis, even a T1 lesion you excise and the whole thing just opens up. And the entire buccal mucosa is wrong. And you may need a flap to close that. Just raising the floor of the mouth will not give you. So either skin graft, which is not really a preferred mode of repair, particularly when there is submucous fibrosis, or a nasolabial flap, or like we often do, a submental flap, provided it is a female, or is not likely to need radiation therapy. The hair growth is a concern in submucous in submental flaps. We here, of course, find submental flap very useful, but the limitation, as I mentioned, are these. In a male patient, if he's not likely to need radiation therapy, then submental flap is not a good option. And if the lymph node clearance at level 1 cannot be adequately done, then of course submental flap is not a. But in carefully selected cases, the results with submental flap survival, flap acceptability, flap versatility is very good, and the local and loco-regional recurrences rates are acceptable like in any other cancer, like with any other flap. So here are two cases that Pranav has shown about a tongue. There are two different patients. One is the tongue, where the flap is more or less mucosalized, and one is in the cheek. And that brings us to the big topic about which are the cases that will need adjuvant treatment in this T1, T2, clinically N0 cases. Tumor grade, what impact does that have? What is the impact of depth of invasion of the tumor? The margin status, lymphovascular invasion, perineural invasion, worse pathological invasion, and the nodal status. I've written nodal status last because really we are dealing with clinically N0 neg. But nodal status has the maximum impact. It is the, like Pranav calls it, the supreme determinant of outcome. If the node is involved, then of course that patient merits radiation therapy. And as we saw in an earlier slide, 30% of the clinically N0 cases of T1, T2 will have occult lymph node metastasis. And N plus disease merits radiation therapy, or in some cases even chemoradiation therapy. If it's a solitary node with very minimal met within the tumor, and your pathology department is diligent in processing all the lymph nodes, then there is a case in identifying or these cases as a subset where radiotherapy may be avoided. If the primary was small, resection was very satisfactory, neck dissection has been done, and you have a single node with minimal deposit of tumor within that node, then perhaps this is a case where radiation therapy can be avoided. But in all other cases of frank lymph node metastasis, radiation therapy will be required in an adjuvant setting. Then if there is extranodal extension of disease, if there is gross extranodal extension of disease, then he doesn't fall into our group at all. But if it is a pathological extranodal disease, where the extranodal extension is minimal, they've seen it as less than 2 millimeter, then do you really need to give chemo radiation, or is radiation therapy enough? Is the question. But if it is a major extranodal extension, more than 2 millimeter beyond the capsule, then the recommended treatment is adjuvant concurrent chemoradiation therapy. So this study really tells us whether it is possible to avoid chemotherapy even in extranodal disease. If it is minimum, then it is avoidable. Patients in this study were divided by extended to minor extranodal extension, that is less than 1.9 millimeter, and major extranodal extension, that is more than 1.9 millimeter. The subgroup with minor extranodal extension had significantly higher disease-free survival and overall survival rates compared with major extranodal extension. So this cutoff threshold of extranodal extension discriminates low and high risk subgroups of patients with occult oral cancer, squamous cancers. And there may be a consideration in these cases of avoiding chemoradiation versus only radiation for minimal extranodal extension. Again, not proven, requires more study. Then the next is tumor grade. Does a polydifferential squamous cancer, we know polydifferential squamous cancers are more aggressive, but does it really merit adjuvant treatment? Is the question one has to try and answer. Depth of invasion is another prognostic factor which we need to study and see whether adjuvant treatment is required in these cases. So if you have a T1 or T2 N0 disease, but the depth of invasion is more, does it merit radiation therapy in an adjuvant setting? And when we say depth of invasion, we have to make a distinction between depth versus thickness. The depth is beyond, deeper to the mucosal level. The exophageal component is not taken into measuring the depth of invasion. Depth of invasion has had an impact on the TNM staging, as you see that the AJCC staging has now incorporated not just the size, but also the depth of invasion. There have been studies that have been done to see whether depth of invasion alone is an indicator for adjuvant treatment in small oral squamous cancers. The study aimed to determine whether increasing depth of invasion resulted in significant deterioration in prognosis and to determine if outcomes differed based on the addition of adjuvant radiotherapy. So this was a retrospective analysis of 1,400 cases. And what it showed was that with every 5 millimeter increment in the depth of invasion, there was a significant increase in disease-specific mortality and local regional failure. In patients with depth of invasion more than 5 millimeter and in the absence of at least one other adverse feature, there was no difference in disease-specific survival, whether post-adjuvant radiotherapy was administered or not. So again, as a single prognostic factor, if the depth of invasion is more, it does not justify giving adjuvant radiotherapy. This study from China has tried to identify a high-risk group among patients with oral cavity squamous cancers in small T tumors, T1, T2 tumors. They had nearly 400 patients, and they were divided between patients with well to moderate differentiated cancers and less than 4 millimeter or more than 4 millimeter, and patients with poor differentiation of tumor with depth of invasion less than 4 millimeter and more than 4 millimeter. And what they concluded finally was that the combination of poor differentiation and a greater depth of invasion helped identify a subset of early cancers, T1, T2, with poorer outcomes. And they may benefit from adjuvant therapy. So as a single prognostic, adverse prognostic factor, addition of radiation therapy is not indicated. But if there's a combination of poor differentiation and depth more than 4 millimeter, there may be a role for adjuvant radiation therapy. Margins are again very important. How good the margins are, whether you have involved margins or closed margins, determine whether you need to give adjuvant treatment. Both from the URT studies and the RTOG studies, both these studies have shown that if the margin is involved, then you need to give them adjuvant treatment. And if the margin is involved or there is extra capsular invasion of the tumor in the lymph node metastasis, then they need chemoradiation as an adjuvant treatment. But for closed margins, there is considerably less clarity regarding the role of adjuvant treatment, like we saw in the earlier one, that one study showed that even 2.3 millimeter margin, which is clear, but does not really benefit from adjuvant radiation therapy. In this particular study, closed margins were associated with more than two-fold increase in the risk of recurrence. Patients with stage 1 to 2 oral cancers and positive closed margins have poor long-term outcomes. And for this population, adjuvant treatment may be associated with improved survival. But closed margin alone does not warrant postoperative adjuvant radiation therapy in squamous cancers. Closed margin with some other adverse factors may demand adjuvant radiation therapy. So one needs to balance the risk of benefit of adjuvant radiation therapy, keeping in mind its significant acute and late toxicities. Lymphovascular invasion is another adverse prognostic factor. Even in node-negative oral cancers, with worse locoregional control and overall survival. But again, as a single adverse factor, it does not merit adjuvant treatment. Perineural invasion is once again an adverse prognostic factor and cause for consideration of adjuvant treatment. But once again, it has been shown that by itself, it does not merit adjuvant treatment. And now perineural invasion has been shown to be, they have seen adjuvant perineural invasion as just one focus of perineural invasion at multiple foci, perineural invasion affecting a larger, nerve, or perineural invasion in tumors in soft tissue deposits. Those are those carry a much poorer prognosis and merit consideration of adjuvant treatment. Evidence is lacking to recommend adjuvant radiotherapy for all patients with head and neck squamous cell cancer with perineural invasion. However, the literature suggests that large nerve or multifocal perineural invasion predict worse outcome and may be a more appropriate indication for adjuvant therapy. So that particular subset needs more attention to adjuvant treatment. The last of the factors, adverse prognostic factors are worse pattern of invasion and tumor budding. If you have a worse pattern of invasion grade 4 or 5, or you have then again these factors bring in the consideration of adjuvant radiotherapy. Once again, not as a single modality, only if they are in association with other adverse factors does one consider giving adjuvant, adjuvant treatment. If I have to just sum up about which are the adverse factors where we need to consider adjuvant treatment in early squamous cancers T1 and T2. One, of course, if it is node positive, there's no question they need to have radiotherapy. If the node also has extranodal extension, which is more than 2 millimeter, then it requires not just radiotherapy, but chemoradiotherapy. If the margin is positive, again, they will require adjuvant chemoradiation therapy. If the grade is high, or the depth of invasion is more, or there is lymphovascular invasion, or perineural invasion, or the worst pattern of invasion is grade 4 or 5, or tumor budding is there. These are significant prognostic factors, but none of these singly justify adjuvant radiation therapy or chemoradiation therapy. Today we start the oral cancer month, oral cancer awareness month, oral cancer month. Thank you. Make some comments.
So it is very important to understand that the pathological evaluation of early cancer